and welcome to Researcher on Call, an interactive series by the Canadian Health Services Research Foundation. Researcher on Call brings together policymakers, healthcare executives, researchers, the public, and you to be a part of a dialogue about ways to improve healthcare for Canadians. I'm Jillian Mulvale, and I'm the Director of Healthcare Financing, Innovation, and Transformation at CHSRF, and I welcome you all to today's session. At this point, I'd just like to mention if anyone is having any difficulty accessing the webinar today, PowerPoint presentations are available on our website, and you can download those and follow along. The website is www.chsrf.ca/researcheroncall, and when you're there, on the right, you'll see a place to click for more information. If you click there, you will get the presentations you can follow along. So again, thank you for participating in our call today, which examines options for physician remuneration in Canada. One often cited source of inefficiency in the Canadian system is its overwhelming reliance on the fee-for-service physician payment mechanism, which rewards physicians for providing a higher volume of services. Alternative payment mechanisms that aim to reduce health expenditures by curtailing the provision of excessive care have been proposed and implemented in Canada and abroad. On March 18th, a small group of invited stakeholders met to discuss policy options for physician payment models. Today's Researcher on Call will expand that discussion to include policymakers, stakeholders, researchers, and citizens across the country. Joining us as speakers today are Pierre-Thomas Léger, Associate Professor of Health Economics in the Institute of Applied Economics at HEC Montréal, and Susan Fitzpatrick, Assistant Deputy Minister of Negotiations and Accountability Management Division in the Ontario Ministry of Health and Long-Term Care. We are pleased to have more than 200 organizations registered today, with representation from every province across the country and beyond. Today's call begins with brief presentations from Pierre-Thomas and Susan, and then we will open the lines for a question and answer period where I'll take questions from you, the audience. Instructions for answering questions will be given at that time. So now let me hand the floor over to Pierre-Thomas.
Hello. It's my pleasure to be here. We'll move to slide. There we go. So there's lots of empirical evidence that shows that the fee-for-service system leads to excessive and inefficient amounts of care. Now, there's also a lot of empirical evidence that shows that physicians respond to financial incentives. Now, it's not surprising that the fee-for-service system is associated with lots of excessive care because it rewards one thing and one thing alone, and that's volume. And so what we would like is an option where we are incentivizing physicians not just for volume, but also to consider the cost of that volume, so both the benefits and the cost of treatment. So I'll move to the next slide. So I just want to make it clear before I start that all of the options that I'll be looking at today should be considered revenue neutral for physicians. So I'm not going to be talking about the level of income of physicians, but rather for a given level of income, how might we want to change the way that we pay them. Okay, so let's consider one of these alternatives, which is known as the mixed payment system. Now, a mixed payment system is like a combination of the fee-for-service system and the capitation payment system. So what it is it provides an upfront payment to the physician for each patient they enlist, as well as a reimbursement like a fee-for-service, but the reimbursement rate is only partial. So it only reimburses a part of the cost. Next slide. So let's examine one of the reasons this combination might actually encourage the right provision of care. So I'm going to consider one example, but we can show that this would work for a variety of other reasons. So consider a case where you have an altruistic physician who is paid by fee-for-service and provides services to a fully insured patient, so essentially the Canadian context. Now, in that type of setting, physicians will want to provide lots of volume. Why? Because it's a win-win. It's a win on the income side because more volume leads to more income, but it's also a win on the patient side because the patient is fully insured. The patient would like lots of care. So it's a win-win. The problem is somebody has to pay for that excessive care, and there's an opportunity cost associated with that care. So we want something is a system that will limit this excess provision of care that's associated with the fee-for-service in the presence of altruistic physicians and also in the presence of insured patients like in Canada. So the next slide. So if we paid, so now take a case where we take the current fee-for-service system and we just bring down the fee-for-service rates. So suppose that we actually decrease these fee-for-service rates such that they were below the cost of provision. Now, obviously, because physicians would be making a loss on each service they provide, they would want to limit the amount of care they would want to provide. On the other hand, they don't want to limit it too much because they care about their patients' health. Now, although this system of having a reimbursement rate that is less than the cost would limit this excess provision due to altruism and insurance, no physician would want to opt into it because they obviously would make a negative income. So what we can do is provide an upfront payment to the physician for taking on the patient. And so what we can do is move around these fee-for-service and capitation payments to get to the right mix of care. So there are other options that are discussed in the paper, but I also want to discuss some possible additions that we might be able to graph onto a fee-for-service system or any alternative. Now, as most of you know, hospitals are paid independently from physicians. So hospitals receive income or revenue from, let's say, a global budget, the government, and with that revenue or with that income, they have to pay for all the services and goods and services at the hospital, except for physician services. Physicians themselves are paid directly by the insurers. Now, what's really interesting in that setting is that physicians actually decide a lot of the costs that are borne by the hospital. And this is especially true in areas like cardiology and orthopedics, where there's when there's a presence of what is known as a physician preference item. So in these areas, drugs and devices account for a lot of the rise in costs, and hospitals would like physicians to care about the cost of these drugs and devices, but currently, because of the independence of these of their payment, physicians don't have to consider these costs, and so there's an obvious misalignment of incentives. Now, next slide. So one important element in the market for these drugs and devices that are very expensive is that hospitals buy them directly from vendors, and they negotiate on prices. Now, one of the things that these contracts have are quantity rebates. That is, the more that a hospital buys of a particular drug or device, let's say a stent from Johnson & Johnson, the cheaper will the per unit price be. And that's because the vendors actually provide rebates when the hospital buys large quantities. So the cost that will be borne by the hospital depends on the collective actions of their physicians. So the more that physicians would standardize on a particular drug or device, the more that the hospital would benefit from these discounts due to quantity rebates. Now, unfortunately or fortunately, depending on the way you look at it, hospitals can't force the hand of physicians. So a hospital cannot force its physicians to use a particular stent over another. Nor can they provide financial incentives for them to choose because of anti-kickback rules. And so what the U.S. has done is they've allowed under strict authorities or strict permission hospitals to participate in a pilot project known as gain sharing. Now, in these gain sharing programs, physicians get to keep part of the savings associated with the cost of these drugs and devices. So, and these are team-based savings. So suppose that you're a team of cardiologists and you spent $1 million last year, and this year your team spends $800,000. Half of that savings would then be returned to the physician team, the cardiology team, which would then split the bonuses equally. Now, there's empirical evidence that shows that this type of system actually led to important decreases in cardiology costs. And the nice thing is that the cost savings were not due to changes towards moving to cheaper types of drugs and devices or using less of them, but rather by standardizing and achieving these discounts that allowed hospitals to buy these things at a cheaper cost. So there's potentially a lot of cost savings without affecting the quality or quantity of care. So I'll now give the floor to Susan.
Oh, thanks very much, PT. That was a great presentation. my presentation, I think, is a good follow-up because I'm going to share some insight into physician payments in Ontario. Physician payments account for roughly one-third of the health budget. And as we know, physicians are critical to the delivery and the success of a high-quality health care system. So we believe it's important to have good data on what is being paid to physicians and also to understand the differences. Ontario now has a lot of different models, and we're reviewing those. So this presentation will provide you with a snapshot of what physician payments look like in the province of Ontario. So I'm going now on to page 11. And I want to highlight in this slide that physician payments have grown on average 7% annually for the last 10 years. This is a large growth, and you can see that it will be taking an increasing share of the provincial budget. Fee-for-service payments, which PT referred to, have grown about 4% annually in Ontario, while non-fee-for-service payments have grown at 22%. And I think this illustrates the shift that our province is making in moving from strictly fee-for-service models into mixed and non-fee-for-service models. So while non-fee-for-service models accounted for only 9% in 2000, they now account over a 10-year period for 29%. So this is a huge shift. And I'm going to now go on to page 12. So when we look at the distribution of family physicians and specialists by fee-for-service income, I think this chart shows a few interesting dimensions. On the upper end, which is box, there's relatively few physicians, roughly 1,000, that are making the high income. But on the lower end, I think the statistic for the general practitioners show that roughly 50% of family physicians are averaging $125,000 annually in the fee-for-service model. And this really represents the shift from fee-for-service as a predominant model of income for family physicians to a blended model. And as I go further into the presentation, you'll see the tremendous shift away from fee-for-service. So fee-for-service is only one component of the income. Moving to slide 13, this slide talks about fee-for-service payments and averages per physician by specialty. And I think it's interesting when we look at how do the average fee-for-service payments go from different specialties, that some of the specialties that PT referred to are on the higher end of the fee-for-service averages. The highest in terms of average income are ophthalmology, diagnostic radiology, and thoracic surgery. And these are specialties that can generate a lot of extra income through procedural interventions. The chart on the right also shows the average for specialists, which is midway down the chart, the average for all physicians, and the average for general practice. And I will comment that the Ministry and the Medical Association have done a lot of work to try to address relativity issues amongst the specialties. So a lot of the investments we've been making over the past 3 or 4 years have been to address the differentiation of some of those average incomes. Moving to page 14, I thought it was useful to give a little bit of insight into where by practice types are the high-earning physicians having their practices. So there's a handful of different specialties. For example, diagnostic radiology, of course, those are the imaging specialties. Internal medicine, some of your procedural specialties do well there in terms of dialysis, echocardiography, and so forth. But I think you can see the theme from looking at this slide, that where there are procedural interventions, that usually leads to a higher income. I'm going to move to page 15 now. I've got one slide only that just shows in Ontario We have shifted a lot of funding towards a non-fee-for-service plans in our academic health science centers and our communities. We have over 300 agreements now with over $1 billion as of our 9/10 data. And there's more work for us to do to determine what this means in terms of individual income to the physician. I'm going to move now to page 16. I want to spend the last few minutes of my remarks looking at primary care because I think it's an excellent illustration of what's changing in the province. On slide 16, then, I'm representing the model that the province put in place to encourage the movement from a fee-for-service model at one end to what is our top model in the province, the family health teams. This was a stepwise or gradient model so that as physicians moved through each of the models, they could make a little bit more income. And this was, I think, early in 2000 when we first started working with physicians and wanted to offer models that would be attractive from fee-for-service. This was a way to gradually move people up the steps. Now, going on to page 17, I've included in my presentation one of my favorite slides because I think this shows on two dimensions some huge shifts. So our big model had always been the family health groups, which is more of a fee-for-service model, and it was growing in the early years. But by about 2007, 08, it definitely had flattened out. And at that time, we offered a remodeled family health organization model that is predominantly capitation. And that model has been highly attractive to physicians, and I think you can see in the dark color the way that wave is starting to expand going out and really starting to capture a lot of the physician from the family health groups. It's interesting to see how that chart will change over time, but we do know in terms of our own registrations that there's a huge interest in the family health organization model, and we actually manage the entry into that model at this point. Going on to slide 18, primary care average payments per FTE, and I think this slide really illustrates why there is shifting in the model. So the family health organization is on average the best paid model and is hovering around $400,000. So this is a very comprehensive model, and for physicians that want to participate in family health teams, we've got 200 family health teams. They have to be in one of the capitated models. Moving on to slide 19, this simply shows for primary care payments where our money is being invested. And again, I would draw your attention to the family health group, which is still a substantial amount in overall dollars, but on the decline versus the family health organization, which is increasing. I would also say it is interesting when we look at all these models that, we have such a variety that there's probably some work to do in terms of consolidation. And I'm now going to move on to page 20. And this slide, I think, can be read a little bit in terms of a previous slide where I referenced where are physicians getting their income. So the majority of the family health group physicians receive less than 25% of their income from a primary care non-fee-for-service model and the remainder from fee-for-service, while the opposite was true for the majority of family health organization physicians, where 70% of their income is coming from the primary care non-fee-for-service income source, and then the remainder from fee-for-service. So these two models, I think, illustrate the big shift that has happened in the province. And my final page is just a little bit on practice overhead, which for those that want to look in a little bit more detail into the data, you can see what the cost of operating the practice is, because, of course, these incomes go to pay the cost of practice. So that is the end of my presentation.
Very much, both of you. We're now ready to take questions from our participants. There are two ways you can pose a question. First, to ask your question verbally, press *1 on your touch-tone telephone. If you wish to ask your question electronically, please use the questions box located on your control panel as illustrated on the slide. When asking a question, we ask that you please identify who the question is addressed to, and please try to ask only one question at a time. Operator, are there any other questions at this time?
We currently have no questions on the phone line.
Currently don't have any? Okay. Well, I'd like to kick off the discussion then. Susan, you've certainly indicated a large number of different payment models in Ontario, and I'm just wondering, how difficult is it in practice to move physicians to a new payment mechanisms, and what kind of strategies you would advise to others who might try to do so?
Well, I think, I was referencing a little bit on the slide that there was an intentional gradient model for family physicians, and I've been working in physician compensation for probably 15 years, and I think, 10 years ago the model was so deeply embedded that it had to be a fee-for-service model. So there was lots of work done jointly with the Medical Association to say, what are the models that will allow physicians to gradually embrace the concepts around the different, capitation models. So even if you look into our grid, the family health group, which is predominantly fee-for-service, it had a little bit of capitation. It started to ask physicians to roster patients, but it didn't put all the parameters. So I think that really has been one of the strategies, is to let physicians move one step at a time. And the other big piece for physicians moving from fee-for-service solo practice is just the governance and organization. There's a lot of time spent in physicians forming groups, getting to know each other, getting their processes worked out on how they're going to work as a group. We also, I think, have done a lot of work with our quality improvement and innovation partnership in terms of providing the support at the kind of the frontline level, and that has helped.
Okay, and just to follow up on that, Susan, it's also a huge amount of complexity, I presume, for folks working within the ministry to deal with all of the different payment models and designs. Could you speak to that a little bit?
Well, I think one of the things, and I comment a little bit on the data, I said at the start it's very important to have good data, but yet we do not have perfect information. Most people fall back to looking at fee-for-service data because it's the data we know and readily available, and our ability to integrate the non-fee-for-service payments, which come out in different incentive payments from different systems and different programs, is very, very complex. So I think even when we look for cross-Canada comparators, like how do our, fully costed primary care models compare to others, we don't have good comparison on that, so we always end up getting back to how we compare on fee-for-service. We are working with our research organization, ISIS, to try to bring all that data together. And one of the things we've tried to stress in terms of our agreement with the Medical Association, that generally physician income should be linked back to their physician billing number so that we can try to get that full view of the income.
Thank you, Susan. That's very helpful. We've now got lots of questions coming in from the audience, so I'm going to switch over there. For Pierre-Thomas, if fee-for-service is decreased and capitation is increased, won't this just cause some physicians to increase volume to make up for the loss, even though there is a capitation on top? It seems to me that when there is any volume component of payment, it will attempt to be optimized. PT? Okay, we'll go to the next one.
No, sorry, I'm sorry. Yeah, could you just repeat the starting of that?
Sure. If fee-for-service is decreased and capitation is increased, won't this just cause some physicians to increase volume to make up for the loss, even though there is capitation as well?
Okay, so the thing that one has to be careful is that when you are providing both a capitation and a fee-for-service component, that the fee-for-service component must always be reimbursed less than the cost of producing it. So what would so let's just take a number. Suppose that it costs $50 to provide a particular exam, one wouldn't reimburse the whole $50. One would reimburse a percentage of that, let's say $30. So every time the physician would actually use that service, the physician would lose $20. Now, that would incentivize the physician to consider the cost, but obviously you can't make physicians lose $20 for every treatment, because then they would obviously make negative income. So what we want to do is add a capitation component to that, an upfront payment that covers these losses, and that also gives income. And so if we play with these things in the right way, we can eliminate this incentive for volume completely.
Kelly, could I comment?
Of course.
Yeah. We have, I think, a good example of that in that we have where we have predominantly capitation models, we have we have built into the models that physician can get a fee-for-service component. And in one of them, for our after-hours services, the fee-for-service component was about 10%. So they got predominantly paid through capitation, and then for the after hours when they billed, they got 10% of the fee. So the fee for service would get 100%. They got the capitation physicians got 10%. They quickly perceived that as only getting paid 10%. So it was a very awkward conversation with them where they're saying, well, why are we only getting 10% for doing the after hours if that's a priority for you? And so I think, where you set that rate, as PT has said, is going to be very, very important because it will have different effects.
Mm-hmm.
Okay, here's another interesting question directed to Susan. I'm wondering what Ontario is doing to ensure that physicians are not gaming these new types of payment options.
Well, I think, what we have to do is go a little bit more into kind of our accountability agreements. All these models have detailed contracts. So there are obligations that they're required to meet in terms of participating in the models. We also have monitoring and review. We look at what's going on. I mean, I think no system's perfect, and we have to kind of, I think, be pretty rigorous in looking at what's going on and following up.
Okay.
Can I speak to that quickly?
Yes.
I think that's a very, very important question. In fact, there's a lot of evidence that in certain types of settings in different jurisdictions where alternative payment systems were put, that physicians did game. And so the most typical case is in the capitation payment system, which will provide an incentive to try to select patients that are low risk. And so one has to be really cognizant of the fact that when you offer these different alternatives, you've got to make sure that you're minimizing the gaming of that choice.
Yeah, and I would just follow up on that. That's a good point because one of our researchers at ISIS, our research organization, has some preliminary data that shows physicians in the family health team model may be de-rostering sicker patients at a higher rate than those in the fee-for-service model. So we've got to look at, why that's happening. But one of the complexities in the system is what we call an access bonus. So if patients seek services outside their rostered model, the physician will lose income. And so there's a little bit of a perverse incentive, again, to have the sickest patients rostered in these models.
Okay, we have a couple of questions that have to do with the issue of outcomes with the new payment models. So has Ontario observed any shifts in patient access or outcomes given the shifts away from fee-for-service? How is that being measured?
Well, I think we get asked those questions every day, and I think some of the observation is going to be over a long period of time. These models, to some extent, probably have about 5 years history, but we have engaged the Conference Board of Canada to do an evaluation, and it's a 5-year evaluation. We're into the third year, so we're starting to see, I think, some benefits of the model. One of the benefits is the access to the full allied health professional team. So there's definitely an improvement in accessing kind of a full range of services. We also have, I think, researchers from different organizations looking at the kind of the cost value of the model. But this is all very, very early on.
Okay.
Can I speak to that just for a second? So I think that when we talk about outcomes, we got to be really careful that when we talk about them relative to specific payment mechanisms. So if we were to speak to Ontario and if we had data, it's likely that the outcomes that we would get in capitation might be very different from the outcomes that we would have if we were on salaried and so on. And there is some evidence that some of these payment mechanisms have led to bad outcomes. Capitation has been associated on some dimensions as providing lower quality, while other types of things like the gain sharing program that I talked about doesn't appear to have any effect on outcomes. And so I think we have to be more specific when we talk about the potential outcome and welfare effects of particular payment mechanisms.
Okay, at this time, I'm just going to check with the operator to see if there's anyone waiting on the line with a question.
Thank you. We have Patricia Forrest with Health Council of Canada. Please go ahead.
Well, hi. Actually, this is Charles Wright, not Patricia. I'm in the office of the Health Council of Canada. Hi, Pierre. Hi, Susan.
Hello.
Hi.
I was going to raise, immediately after your presentations, I wanted to raise the issue of contracts, but you have done so, Susan, very appropriately, because you hadn't raised it up until then. I mean, to me, this is one of the most important aspects of changing the payment system universally, because we have the astonishing situation at the moment with many, if not most, physicians who really don't know what a contract is and certainly are not working under one. So I wanted to be sure you've mentioned it, but just how rigorous would that be to include all relevant activities? Would not be the same, obviously, for every physician, but would include things like clinical, teaching, research, administration, evaluation, and so on, and what about the mechanism for management or oversight of the contract?
Well, I think that's an excellent question, and I think one of the questions was what's the burden of effort on the ministry, but I think moving 24,000 physicians from fee-for-service, which is probably a fairly efficient model, into one that's more based on contracts has been, a huge workload, and I think very, very difficult work. So all these models now have contracts. Some have template contracts that we work with the Medical Association on. We have a fairly detailed family health team contract that lays out accountabilities. And then for our alternate payment programs, I've illustrated there's 300 contracts there. So the contract work is very, very complex. And I think one of the things we've got to shift to is a little bit more standardization and then focus on the accountability. And we're probably not doing as much as we can to make sure that we're looking at what do we want out of the contract and then are we getting that. In the academic model, we do have a committee and we're producing annual reports on how is our investment through that contract arrangement actually producing the results we want to see. So there's, some minimum requirements in terms of service volumes and so forth. But then what are the other benefits of putting that group into the contract?
Okay, operator, did you have another call at this time?
Yes, thank you. Your next question comes from the line of Sean Brigid with Manitoba Health. Please go ahead.
Yes, it's Jide Babalola from Manitoba Health, and my question is for Susan as well. And this is in regards to the overhead table that she put up. We were just wondering if she can explain a little bit about the methodology behind that overhead calculation, and if there are documentations that she can share with us regarding that methodology.
The latest, I'd be pleased to do that. If you leave your name with me, I can follow up on the methodology. It's hard to go through it on the phone, but the ministry and the OMA, as part of our agreement, did work on an updated methodology, affectionately called the CANDY methodology. So we can share what we've done there, and what it really looked at was income per day. And then it was used to try to allocate money towards the kind of the lower end of the specialty averages.
Okay, thank you.
And also, this one may require follow-up as well, Susan. It's from Pat Duncan with the Government of the Yukon.
Mm-hmm.
She's wondering, could you please provide a more complete description? This is probably addressed to both of you. A more complete description of the payment models, or direct people where a more complete description might be available.
Yes, I can. I mean, I think that there's probably information on our website, but we do have detailed information on the primary care models and the specialty contracts.
Okay,
and I could and there's a lot of academic work that's looked at this, but unfortunately it's a bit sort of scattered. And so I think the easiest way is, I know that the Institute of Health Economics in Alberta had a book on healthcare financing, and not to toot my own horn, but I wrote the chapter on physician payment mechanisms, and so that should give you a sense of all of the potential options and at least a good set of references for where you might find some further reading.
Okay, great. Another question, I'm not sure who it's directed to, so maybe you can both take a stab at it. Under capitation, there is a risk of physicians selectively enrolling healthier payments in the U.S., patients. In the U.S., capitation payments are adjusted for morbidity or healthcare need in order to reduce this risk.
Mm-hmm.
Has morbidity adjustment of capitation payment been considered in Ontario? And that's from Lynn Sibley.
The one thing I will say is part of our agreement, we have a capitation working group, and we're certainly looking at what we could do to bring in more complexity into the model. So right now it's age and sex, and we want to try to add another modifier, which would be for very complex patients. And again, I've referred to ISIS doing some work, but they're very much, I think, looking at the U.S. model. Decisions on that won't really be available till later this year, but I think that that's probably where we're going to try to move.
So I can speak to that too, and that essentially this risk adjustment is hopefully fine enough so that everyone essentially has an expectation, the same income for the physician. The problem is that these risk adjustments are often very insufficient to capture the expected cost of providing care to these patients, and physicians can observe some of these or set up types of contracts or types of shops that encourage within certain groups more healthy patient to select into sort of to the capitation. So a nice anecdotal story is one where we saw in Florida where the capitation payment led some offices to set up shop on the third level of a building. And so what you would get in a rich neighborhood, so you would essentially select on wealth, which is correlated with your expected consumption, and then select on activity. And so essentially this group was getting relatively healthy patients. And so that's what we fear, is that if some people are selecting, then we're going to get some people who will not be able to find easily physicians willing to take them on. And so it's both a theoretical but an empirically very difficult thing. And so one has to be really careful about that cream skimming potential.
And I think one of the things we've observed here is when we went to different physician groups and saying, why aren't you moving from the family health group model to the capitation model, the ones that had a lot of very difficult patients, whether they were street people, mm-hmm. people with serious mental illness, HIV and AIDS, they could not make the shift work mm-hmm. because they would actually lose money. And we had to do a lot of work to kind of recognize that those populations are not well represented in the average capitation rates.
And finally, the irony of that is that hopefully the goals of capitation is that it allows for better management of chronic diseases.
For sure.
So because if you have a patient enlisted with you for a long period of time, you have an incentive to keep them happy. And so once you have a patient, happy and healthy, but so once you have a patient, you have an incentive to keep them keep them healthy, but if they're too expensive, you have no incentive to take them on in the first place. Mm-hmm. And so it's sort of defeating one of the goals of capitation.
Exactly.
Okay, another question, and this is getting at the gain-sharing model. So this is from Ashley Hogue. Are any hospitals in Ontario or Canada looking at implementing the gain-sharing model?
So my understanding is that the gain-sharing models that exist are really sort of a weak form of gain sharing, in the sense that these vendors are providing to cardiology teams small amounts of money that they can then use for equipment or education purposes, but these are very, very small, and they come in the form of sort of goods for the team. It is currently not, I think, legal to set any type of direct payment from the vendors or from the hospitals. So I think that there's probably going to be some regulation changes or regulatory changes for any provincial government to really take this on.
I think I would just add, and Charles writes on the call, but in one of our agreements with physicians, we did try to look at standardizing hospital devices, and it got to be very, very complex. I mean, I think we made some progress, but it wasn't presented as necessarily a gain sharing, but more what could physicians do to help hospitals, just as you've indicated, that they make a lot of decisions that affect the global budget, but they're not accountable for it. But it did get a little bit bogged down, so I know it is a bit of a tricky area.
Okay, the next question is from Don Husserow. Can you elaborate further on what is being done to reduce inequalities across specialties in regards to income? Okay.
Yeah, I was. What we have done under this agreement with the Medical Association is that the average increases, we negotiated a certain amount each year. Half of that would go to each specialty and family physician, and then the other half would be rated in terms of relativity. So if you were in the high-end group, such as ophthalmology or cardiology, you would get no money out of the relativity adjustment pool. And if you were in the low end, I think the geriatrics and so forth were in the lower end, you would get a much higher rate. So that was trying to shift the money to those that are on the lower end. And, you know, whether we'll continue that, our agreement comes up in 2012, we'll have to kind of assess whether we think we've made enough progress in that area or not. And I think the other piece that I did say in my presentation, it's not all about the fee-for-service. So some of them, the specialties that tend to be on the lower end, we've put in more attractive alternate payment models to address their income needs. I think psychiatrists, geriatrics, infectious diseases, geneticists, and so forth are going to have models that actually bring them up to a minimum payment level.
And can I just mention that these things are just not about equity. I mean, there's some strong evidence that suggests that physicians actually consider these their expected income across these different specialties when choosing. And so if you don't pay relatively well in one specialty, then you're likely to have a difficult time, competing against the others, and that could have some important implications on, the supply of certain types of services. And so I think it's a real issue.
Yeah, and I wonder kind of about a little bit of the political side of it, because I think, some of the specialties that do very well have a lot of influence in the system.
Okay, I'd like to check with the operator again now to see if there's more questions waiting on the line.
Thank you. We have a question on the line from Emeka Ekwansimba with the Government of Alberta. Please go ahead.
Yes, hi. My name is Emeka, and my question is directed to Pierre-Thomas. I'm just wondering, now, it seems that we are quick to condemn fee for service, and we just want to jump into new models, capitation, and the rest of them. But I was wondering, have we considered correcting the problems associated with fee for service model, for example? For example, using the RVG guide system, the relative value guide system, as obtainable in the U.S. and some provinces in Canada.
So, first of all, I don't mean to malign the fee-for-service system in the sense that there are some benefits to it. However, and we haven't gotten into all of them, but there's a lot of perverse incentives with the fee-for-service. And the other really important thing is trying to get those actual fees correct. And so the problem is that as soon as one type of service becomes more lucrative to another, then there's a tendency for physicians to direct towards the more lucrative one. The other thing that I have to speak to is that the fee-for-service is one that has, provides a lot of incentives for quantities of care, so treatments and services, but it doesn't reward. In fact, it punishes physicians who provide a lot of unobservable but valued types of care. So think about the time the physician spends with their patients, the amount of time that they look at, finding the right diagnosis and comforting the patient and actually explaining the treatment options and so on. These are things that are very costly for a physician to provide and that aren't at all being rewarded in the fee-for-service. So I think that there's just not the cost issue, but there's also this issue of how do we get physicians to provide the right basket of goods. Finally, just to say that when I was talking about this mixed payment system, one can really just think of this as a small variation on the fee-for-service. And so what you're not throwing out, the baby with the bathwater. What you're saying is there's a fee-for-service system. How could we tweak it such that there's all of this to correct these sort of disincentives, and the way that we tweak it is to sort of decrease these rates while then providing an upfront payment. And so I don't think that these things are necessarily that difficult to institutionalize, whereas a move completely to capitation, I understand, is a much bigger shift.
Okay, the next question from Linda Lukes. For either speaker, by the look of the graph, the overall costs have not stabilized, but rather continue to rise. How are you anticipating the alternative models will contain costs? So what is the strategy? Have you looked at quality outcomes and unintended consequences?
I would just say for our kind of growth curve in Ontario, one thing that's driving that growth is moving people between models. And the graph I showed where we're kind of in the midst of that conversion. So we do have growth in terms of that change. And then I think when we get to kind of an end point where people are in the models and the growth will taper off. But I think the rate of growth is obviously a concern, and that's, I think, areas we will be looking at. And one of our focuses now through the Excellent Care for All is like quality and evidence. And that gets a little bit to our discussion, are we providing too much volume of service, and what does the evidence say about that? So we've brought forward, I think, about 3 or 4 packages of changes that try to fine-tune the fee-for-service a little bit more to say we're not going to pay in this circumstance or that circumstance, which is supported by evidence.
So if I could speak to that, I think that, it's the $64,000 question is how do you bend this cost curve? And in fact, I don't think that, physician payment mechanisms can do it alone, nor is it likely to be the same across different specialties. But I'll just provide one sort of striking piece of evidence. If we go back to the cardiology example and we look at the increase in costs in cardiology over the last 10 years, much of that, if not almost all of that, is being driven by the costs of these drugs and devices, and not from labor costs. It's like 98% of the cost. And so if we can actually save on these drugs and devices, we're likely to have, some important effects on sort of the growth rate, because that's where the actual source of growth is coming from. That's unlikely to be the case in other types of specialties, but I think that a combination of these things are probably needed. From the financing rules to the insurance rules to the payment rules and so on.
Okay, another question from Michael Sheltkin for Pierre-Thomas. Why not salary for specialists in particular?
Right.
It is used by the Veterans Administration System in the USA, the Mayo Clinic as well as Dr. Brian Day's clinic and the Copeman Clinic, not to mention the NHS in the UK. Mm-hmm. This would reduce zeal for high profit but low marginal effectiveness treatments.
So it's true that salaried physicians exist in academics, and in places like Mayo, one has to be extremely careful when one tries to generalize these results to the general population. The Mayo Clinic is by no means a typical environment. I think it's very important, though, that we consider the perverse effects potentially with salaries. First of all, there's an incentive to maximize. So there's no incentive to consider costs, right? And there's not a lot of incentive to provide a lot of effort because it's guaranteed income. And in fact, I've seen firsthand some very perverse effects of that in academic specialties, because we see a lot of this medical arms race happening in university and large centers that pay salary because these expensive types of tools attract patients, but they have very little marginal benefit. And the physicians themselves don't need to consider the cost or the benefits of these treatments because their salaries are invariant to it. So I think that the salary has some potential positive effects, but one really has to be cognizant of the fact that they do nothing with respect to cost control beyond reducing this incentive to induce care.
And I would just add, I think, like physicians by specialty are quite different. So I think salary does work for a lot of them. Like, for example, lab physicians in Ontario are largely salaried. And I was talking about infectious disease geneticists. And some of the specialties where really their services are somewhat low volume are probably better on a salary model. And then, some of the high end where I think we haven't made very much progress in getting them off fee-for-service, I think, we need to think about, how do we get them on more of a blended model.
And a nice example of that would be psychiatry. One really has to be careful about providing incentives, disincentives to care or cost containment in certain types of areas. And it's unlikely that psychiatrists most of that is labor costs, and likely not a function so much of inducement. So I think one has to be, it's probably the case, yes, that certain types of specialties are more are better off with salaries than others.
Yeah.
Okay, we've just got about 5 minutes left, so I'd just like to check with the operator once more. Do we have any people waiting on the line?
Yes, we do. We have two questions on the phone line.
Okay.
We have a question from Marianne Williams with PCC. Please go ahead.
Hi. Thank you. I'm wondering if there is the potential for a greater role through private insurance or health benefits to assist with the coverage of basic services. Has that been?
So this is. I'll answer that very quickly because and you're talking about the insurance, private insurance for the patients.
Mm-hmm.
Yes. So
this
is sort of a very different topic about sort of insurance reform. But one of the things that has been looked at is how people respond to insurance levels, and the other thing is how does the market respond to the presence to private insurance. Mm-hmm. And the problem with private insurance often is that it's more lucrative than public insurance, and so physicians have an incentive not only to moonlight but to actually sort of transfer patients towards the more lucrative private pay. And so it can have some perverse effects. It can also have some effects that are non-negligible on equity of care. And so it's a huge subject that's certainly not going to be answered here in 2 seconds, but I think that there's a lot of perverse, potentially perverse effects of allowing a competition between the private and the public in the provision of health insurance.
Okay, I've just got the signal that because there's still so many questions and our speakers have agreed in advance, we will continue for about 5 or 10 minutes past the scheduled shutdown time at 1 o'clock. So if you want to stay on the line, we'll continue. I'm going to try to combine two questions here, one from Jordan Sauer and Lori Gabanis, which are very similar. They're both essentially looking to PT to say, in his opinion, what jurisdictions have it right. They found a good way to compensate physicians in a way that controls costs, leading to good quality outcomes, and really have that sort of mixed model that we could aspire to here in Canada?
Wow. I think, it's not easy to find a jurisdiction that, quote unquote, has it right, because there's a lot of elements to what is right, and every type of payment mechanism has some benefits and some costs. But I think that those that have looked at using this blended model, and I'll just give you a real-world example of that happened in Quebec and that was studied, and I thought that it was a really nice contribution, is there was a lot of complaints that university faculty who do a lot of teaching and who do a lot of administrative work had very little incentive to provide that type of valued good to the community under the current fee-for-service. And so the Quebec government allowed physicians to opt in to a mixed payment system where physicians would receive a sort of a per diem and then a lower fee-for-service rate. And what physicians responded was by actually decreasing the amount of visits or some of these cares, but they actually spent more time with the patients, and so and there was a lot of they spent also more time on teaching and more time on administrative work, and so I think that there's a real world example that occurred in Quebec and in Canada that seems to have worked really well, and so I think we need to look at those potential options, and obviously if they could do it here, it's something that could be done across Canada.
I'm just going to give a plug for my own province, but I think our Academic Health Science Center model is not a bad one because we have two different offerings. One was a fully converted capitated model, and another was a fee-for-service model. And some of the academic sites that are larger chose to stay with a predominance of fee-for-service, but then used a blended payment component to try to deal with some of the clinical inequities in terms of payment, and then augment the teaching and the research. And then the fully converted capitation models chose to increase their fee-for-service component to try to deal with some volume issues. But again, in both of those models, it was really looking at how do we, sustain the teaching and research, and we have also had a very successful innovation component to that.
Okay, next question from James. I'm not sure if it's Isles or Ailes. I apologize. Does location, that is being an urban, rural, or remote area, have an impact on the payment mechanism that physicians select?
Well, I don't know if I'd have to look. I suspect that there's a lot more things like for salaried in the urban centers because academic hospitals often pay by salary. But I would be interested myself to see the geographical location. What's interesting is also that we know that physicians locate conditional on a fee-for-service the rate or the type of payment. We know that the differentials in payments actually influence the location decision of physicians. And so if it turns out that for some reason we're paying more of a particular type in rural areas than we are in urban, then we might have to look at both the level and the way that we pay to attract them. But I don't know if there's anything really that limits the use of these other systems outside of urban areas. I don't see why they would.
I think we've done a lot of work with the northern and rural physicians to make sure they have a variety of models to choose from. And usually there's rurality kind of recognition, so there's different scores. If you're more rural or more remote, the model would recognize that and pay more. We have a few northern programs that I think have helped sustain it. We have a northern specialist contract, and we've also got work we did with the Northern Medical School in terms of the physicians that are working there. They're part of the Academic Health Science Center contract. So I think the short story on it is that probably physicians in the northern and rural areas find it hard to be on 100% fee-for-service, and I would think if we looked at it, most of them will have other components of income supporting it.
Okay, although Tobias Gelber has left, I think it's an interesting question. Can either speaker speak to pay-for-performance models as an addition to the existing payment models?
So that's a really interesting topic, and there's been not surprisingly, lots of interest on P4P, and the empirical evidence is just starting to come out. One thing about the P4P is that obviously it rewards, its goal is to reward quality. So there's a lot of evidence that suggests that even though we spend a lot on care, there's still some really bad quality scores often for a lot of treatments. And so what we want to do is incentivize physicians to provide high-quality care. And so the way that we do that is we either pay them when they adhere to certain procedures or they would get a bonus if all of their for example, all of their patients had mammographies, or we can actually reward them for the outcome. Now, both of those things, although are set up to increase quality, they allow the potential for gaming. So, for example, if you provide rewards for process, for actually doing certain types of things or providing certain types of tests, then you get the multitasking problem where physicians will want to or will have an incentive to teach to the test. So you have an incentive to go and do the things that are going to be measured and not to necessarily do the things or to avoid doing the things that aren't going to be measured. It also causes a problem of selection. So if you pay docs as a function of how well their patients do, then physicians will want to select patients or try to select patients that respond well to treatment, that adhere to their recommendations. And so then there's the final question is, how do you measure outcomes if you're going to use outcomes? And so that's not an easy task, and even if you can perfectly measure outcomes, which is impossible, but even if you could, it's very difficult to identify the contribution of the physician. So P4P is something that is, I think, promising, but one has to be really careful because there's a lot of opportunity for gaming.
We've got what we call $100 million in collaboration initiatives, and they don't go as far as outcome, but two of them. One was to address the problem that we still had unattached patients that couldn't get a family physician. So it was set up that if on a local level the physicians were able to get together and deal with all the unattached patients, they would get a bonus at the end of the year, and that worked very successfully. It wasn't the only thing we did. We do have a registry for patients, but that kind of galvanized attention around that because we felt we've got enough supply. Why are these patients out there that can't get a physician? Mm-hmm. And then the other is we also used it in ER, so in hospitals that were having a trouble making their ER wait times for the low acuity, which are very much influenced by physicians. If they made improvements in the wait time, then the physician groups would get a bonus. Now, I think the verdict's out a little bit about whether the amount of effort to set up the funds, monitor the results, and so forth has been worth it. But we will certainly look back and see what progress we made through that approach.
Okay, and I think this will have to be our last question for the day from Donna Clare. Why are salaries physicians not on the table? Other primary care providers like nurse practitioners in Ontario are salaried and clearly do not exclude care for those with complex issues. Can salary with a contract for quotas, capacity, and efficiencies be considered?
So that returns to the problem that I was talking about, cost containment. So yes, salaries will reduce this perverse incentive to simply max out on volume, but it does very little for cost control. And so if we take the example of cardiologists, we wouldn't want to pay them on salary because if we did, then they don't need to care about these costs of these drugs and devices. And so for certain types of specialties or for general practitioners, that might be a more viable or a type of payment that is unlikely to have really large perverse effects. But if you would have to supplement this with a bunch of other things, as they said, how many patients you can see. But then if you put limits, you put a quota on the amount of patient that one must have, then physicians have an incentive to select patients that don't take up a lot of their time. And so you fall into these issues of selection and of cost containment, which, are quite frankly very important, especially in a lot of specialties.
I think it's a complex question. I know other jurisdictions, may have made it work, but I think we'd have to be really careful shifting to it because I really do worry about the effect on volume. And while there's areas where we're trying to drive access improvements, I always want to make sure there's a little bit of incentive for volume because I think when you remove that altogether, then you may have other issues to deal with.
Okay, well, unfortunately, we're out of time for today. If you have submitted a question that we did not get to yet, we will ensure that your questions are forwarded to our speakers for follow-up. This has been an excellent session. Thank you to both of our speakers. We hope you will join us again in the future, everyone on the line. We encourage you to sign up for @CHSRF if you go to our website, www.chsrf.ca, to stay up to date on future sessions. We would also greatly appreciate your participation in a brief survey about today's Researcher on Call. Once you exit the webinar, an electronic survey will launch automatically, and a follow-up email with links to the survey will be sent within the next 24 hours for those of you attending only by phone. Most importantly, a sincere thanks to Pierre-Thomas Léger and Susan Fitzpatrick. Also, we thank you, our audience, for your participation today. That concludes today's Researcher on Call. Thank you again for joining us. For CHSRF, I'm Jillian Mulvale.